blood disorders and COVID-19 and the risk to the patient and what should they be doing. So in this topic, the discussion that we will talk about four basic diseases today. We'll do some more later on. One set of diseases is the hemoglobin disorders, in which we'll cover today the sickle cell disease and thalassemias and what is the risk to the patient if they get COVID-19 as well. And the second set of diseases that we would handle today are going to be the clotting factor disorders, in which especially the von Willebrand disorder disease, or factor disease, and then the other one will be hemophilia A. So these are the things that we would discuss. Let's start our discussion. Good morning, everyone. Welcome. And we're talking about the blood disorders. So let's start. I'm going to share my screen as usual, and we will go over some of the studies, and we will go over the diseases and what is a risk that patient needs to take care of. So, all right. So these kind of discussions are interesting. Let's start. First of all, here is what we are going to talk about. Blood disorders. In these blood disorders, today, so we may do a part 2 later on, but today what we'll talk about is the hemoglobin disorders and the clotting factor disorders. Within the hemoglobin disorders, sickle cell and thalassemia, and then the clotting factors. If I can just very quickly provide you a summary of all of this, then it is really up to you then to continue for the rest of the discussion or not, but at least you would know the summary of it. My request to you is please make sure that you subscribe, like, and share this as well. So here is a summary. Sickle cell disease patients are the most at-risk patient. And the reason for that is the sickle cell disease causes the vasoocclusion. That means that the cells that become sickle, they get stuck in the blood vessels. That causes the obstruction of the blood flow, that causes necrosis, infarction, which then in turn can cause damage to the tissue, or does cause damage to the tissue. This is specifically important when there are infections of the respiratory system, which COVID-19 will cause. So we will go over the mechanism of that. That means sickle cell patients need to be extra vigilant if they get the COVID-19 infection. And if that becomes serious, they can develop acute chest syndrome and vasoocclusion in the lung or pulmonary area, becoming very severe. So that the disease becoming severe and their situation becoming bad. So that is sickle cell. Thalassemia, on the other hand, usually do not have a high risk from COVID-19. The only problem with the thalassemia is the spleen. If their spleen is removed, which can happen in sickle cell as well, then there may be secondary infections that can occur with COVID-19, and that can cause an issue. So we'll talk about that as well. On the clotting factor side, this side, von Willebrand and factor VIII deficiency, both of those deficiencies can predispose a patient to bleeding disorders. That is what it is. Hemophilia are bleeding disorders. And the problem with that is that, remember, if the COVID-19 becomes serious, then there is hypercoagulability state, correct? For the hypercoagulability, we need the clotting factors. And why is there hypercoagulability? Because there is vascular damage going on, and we need to plug that damage. We need to stop that damage or plug those injured areas with clots or thrombi. And if we cannot make clots or thrombi because of this blood clotting factor issues or because of hemophilias, then the patient would start bleeding internally. So that is the basic problem over there. So again, the patients with hemophilias or von Willebrand disease or factor VIII deficiency need to be extra careful. These diseases do not directly cause or interact with COVID-19, but if COVID-19 becomes serious and causes hypercoagulability, then we need the factors to be able to allow the clotting to occur and the bleeding not to occur. So this is the laydown of the discussion today. If you just wanted to know what is the risk, then this is it. Now we are going to go over the mechanisms. So we'll go from here. And Ria, I see what you're doing, and I will be reporting you to YouTube today. I have gotten a few people blocked already, so we'll get you blocked as well. So you can do what you want today. Tomorrow you'll be out. Okay. So let's continue. First of all, we'll start with the sickle cell disease. So look, sickle cell disease, here is a normal RBC sitting here. We know that RBC, when it is formed, it loses its nuclear material, and really it becomes a bag of becomes a bag of hemoglobin. So in here, I have made chair-like structures. So if you see here, these are the chair-like structures in here, which I have depicted them as hemoglobin. And I want to talk about what does that mean. Look, a hemoglobin, I've done this discussion many times before. A hemoglobin, a globin structure or hemoglobin chain is made up of following structure. There is a porphyrin 9 ring, which is something like this chemically. So this is a ring which is called porphyrin 9. Porphyrin 9. This ring has ferrous in its center. Ferrous is iron with two ionic charges. And then on the other side of it, on one side of it, is a globin chain attached with it. Globin is nothing but a globular protein. So this is a protein. And then on the other side, so let's say this is the orientation. So this side is a globin chain. On the other side, oxygen molecules can come and attach. This is called a heme chain. 4 such chains come together to make a hemoglobin molecule. These molecules, you can think of them as chairs. So see, chairs have 4 legs. Same way, hemoglobin molecule has 4 chains in it. And those chains are usually made up of either, so if you see here for a second, these are usually in adults, us, we have alpha chains and beta chains. They are slightly different in their composition, but we call them alpha and beta chains. So normally one tetramer or tetramer means that 4 such changes. If I come back here like this, so there are going to be 4 chains of hemoglobin that will come together, or I shouldn't say hemoglobin, heme chains will come together and make one hemoglobin molecule. The problem in sickle cell disease is that these red chains that I made, these are beta chains. So there are 2 beta chains and 2 alpha chains. These beta chains are defective. So that is the difference between sickle cell and thalassemia. In sickle cell, the beta chains are defective. In thalassemia, the chains are absent. There can be alpha chains that are absent or beta chains that are absent. So at this time, just visualize that there is a chair. The chair has 4 legs. 2 of the legs are called alpha and 2 of the legs are called beta. So when they all 4 are present and 2 alpha and 2 beta are present, we call it adult hemoglobin. Now let's think about what happens. Before we go to the sickling of the RBC, also note that RBCs have to pass through capillaries. Capillaries are the smallest part of our cardiovascular system. They are the smallest tubes through which the RBC has to go. And capillary normally have a diameter between 5 to 10 micrometers. And an RBC has a diameter of about 8 or more micrometers. So imagine this, that now this RBC has to go through this capillary. So do you know how it goes through this? It kind of squeezes in like this and pushes through. So let me make it again. It kind of squeezes in like this. So it has to bend when it has to pass through a capillary. Correct? So it is important that the RBC contains the flexible structure so that it can flex and bend and squeeze through the capillaries. If it cannot do that, it would occlude the capillary, it would occlude the blood supply downstream, causing ischemia and necrosis and the damage to the tissue. This is what happens in sickle cell disease patients, that their tissues start becoming ischemic. So now let's look at the mechanism of sickling. How does sickle cell actually work? So first of all, we have this beta globin chains that are defective. That is a basic problem. So here we have a normal beta chain. So again, if you see here, this is the porphyrin ring on top of it. This is the beta chain itself. On the 6th position of the protein chain, there is an amino acid called glutamate. And keep this in mind that the glutamate has this negative charge on it. This is very important to keep in mind, that the normal beta chain on the 6th position or the 6th amino acid is glutamate amino acid, which is negatively charged. What happens is, in sickle cell, either trait or disease, I'll explain what these are, there is a genetic issue where instead of glutamate, the 6th position is occupied by valine. Valine is another amino acid, and valine is neutral. It doesn't have a charge. Because it is neutral, this is a very interesting thing. The proteins, the amino acids that make proteins, they have charges on them. And with those charges, these amino acids hug each other and bind to each other and create a specific shape of the protein. Here, the valine was supposed, over here on the 6th position, we wanted to have a negatively charged amino acid. Instead of that, we have a neutral amino acid. So there is a bump in this protein. Here, do you see this? There is a bump in this protein, and this bump is the problem. What will happen is that this bump will then start fitting into other normal alpha chains. So see, there is a position here, there is a place here in the alpha chain where this bump can fit in. That is a basic problem in sickling. So now imagine that, let's say there is a patient of sickle cell disease. Sickle cell disease means that both beta chains have the same issue. Sickle cell trait means one beta chain has the issue. So out of the 4 legs, 2 are of the chair, 2 are alpha legs, which are fine. 1 beta leg is fine as well, and 1 beta leg may be defective. Or you can also think it this way, that out of the 4 legs, some chairs have 2 alpha, which are good legs, and 2 beta, good legs. And then some chairs have 2 alpha, which are good, and then there is a defective beta leg as well. The outcome of that is that some of the hemoglobin is working fine and some of that is not working fine. So patient doesn't even know that they have the problem. So this is sickle cell trait. When the sickle cell disease occurs, that means both beta legs in the chair. So here, both beta legs, if you look at this one, see these red ones are beta legs. Both beta legs in a molecule, this is one molecule, are defective. And what they do is that they go to another molecule, which of course these molecules of hemoglobin are sitting in RBC, so they are in close vicinity. So these guys, when they are in the close vicinity, the beta chain of one molecule gets connected with the alpha chain of the other molecule. And if you keep doing this, you would see that there will be a chain of molecules that would form. This is what we say precipitation of hemoglobin. This is what is called the precipitation of hemoglobin. This is what makes the crystals of hemoglobin inside an RBC. So here we have an RBC that has these long crystals of hemoglobin formed in it. And guess what it does? That crystal formation does two things, and now we are connecting it with COVID-19 as well. One is that those long crystals, they kind of tend to stick into the membrane of the RBC and give it that sickled-like appearance. Second thing is they make this RBC non-flexible. Imagine we have a bag, and inside the bag we have a long stick. And that long stick is now keeping the bag straight. So until you bend the stick, the RBC is not going to bend. So when the RBC becomes sickled, it cannot pass through the capillary with that much ease because now it is elongated. And that would cause the RBC to get stuck in the capillary mouth. And that would cause the blood supply to occlude to whatever viscera it is, for example, liver or kidney or skin or lungs or whatever. That would cause ischemia and necrosis. This is very painful, plus there is tissue damage. Now imagine with this background with the sickle cell, imagine what happens. And sorry, one more point before we go there. Sickling occurs. It's not that all the blood cells are always sickled. Normally, a fresh blood cell that is made, so let's say if I make a blood cell today, that would not be sickled. But slowly, when it passes from the areas of my body where there is more acidity or where there is less oxygen or where there is less water, this is usually going to happen in the areas that are functioning and working. Working tissues produce acids and they take up oxygen and they consume water. So there is dehydration, and if I drink less water, I'll be dehydrated as well. Plus there is acidosis. All these three conditions cause sickling to occur. So now think about it. Think about it for a second. In case of COVID-19, what is the problem? COVID-19 comes into our body, goes to our respiratory system, our lungs here. And what does it do? It starts causing pneumonia. It starts causing problem with oxygenation, which will cause hypoxia, which will cause acidosis. Whenever our body works without oxygen, we start producing lactic acid. That is acidosis. That is an anaerobic issue. So now what is going to happen is that in a COVID-19 patient who also is a sickle cell disease patient, they would have hypoxia in the lungs, which would precipitate sickling of the RBC in the lung, which would cause acute chest syndrome. These patients normally get acute chest syndrome with other infections as well. COVID-19 is a very aggressive infection. So sickle cell disease patients will get vaso-occlusive issues and acute chest syndrome, which means that the blood supply to the or the blood vessels in the lungs are going to become occluded, which would cause severe damage to the lungs, can cause further inflammation and hemorrhages inside the lung, then cause further infections and damage. So that is the problem with the sickle cell. In addition to vaso-occlusion and acute chest syndrome, if the patient of a sickle cell disease already is hypertensive as a comorbidity, then we have had that discussion as well, that hypertension itself does not matter, but hypertension is an indication that there is load on the heart and cardiac tissue is under stress already. And we also know that the COVID-19 or SARS-CoV-2 likes to bind to the cardiac tissue and damage that as well. So patients with hypertension are at additional risk, the patient of sickle cell with hypertension. Similarly, patients with sickle cell with renal disease, and this is very common as well, that the sickle cell patients have kidney damage as well because the sickling occurs in there as well. And why does it occur there very often? Because kidneys are very highly working tissue. They extract oxygen, they need a lot of energy, and the environment can be relatively hypoxic under any stress, and that can cause sickling, which would then cause damage to the kidney. Now, damage to the kidney also is a problem for COVID-19 patients, because one of the major visceral failure or organ failure they get is kidney failure. And then fourth thing that goes on with sickle cell patients, which is dangerous in COVID-19, is that some of the patients may be using hydroxycarbamide. Hydroxycarbamide prevents sickling, or it reduces the sickling. However, it is a deoxyribonucleotide suppressing agent. What does that mean? It reduces the formation of DNA. So when the formation of DNA will be reduced, that means bone marrow will be suppressed, correct? Because in the bone marrow, we are making cells all the time. And to make the cells, we need DNA. And if we are giving hydroxycarbamide to treat sickle cell, then what we are going to do is that we are going to make the patient immunosuppressive, mildly immunosuppressed. And that in turn would cause the COVID-19 to more rapidly progress. Now, why is hydroxycarbamide used in sickle cell? It's not used to cause immunosuppression. In fact, what happens is hydroxycarbamide promotes the formation. So see that chair we talked about? That chair had 2 beta chains, correct? And it had 2 alpha chains. So let's say this is that chair. It's a weird chair I made. Let's make a chair leg here. And we'll take this leg out. And let's say this is the chair. And the chair has, so there are porphyrin rings, and then this is a tetramer. So this is a hemoglobin molecule. Now, instead of having beta chains, what we can have is we can have gamma chains. Gamma chains are a different type of chains. Normally children or fetuses have them. So let's say these are the gamma chains. Gamma chains can work fine as well as compared to adult. Hemoglobin, that works fine as well. Adult works better. Gamma chains work better in a fetus because they bind oxygen with more firm affinity. We don't want that when we are adults. But anyways, the gamma chains are actually better than beta defective chains. Hydroxycarbamide increases the formation of gamma chain hemoglobin. This is called hemoglobin F, or fetal hemoglobin. So it helps create fetal hemoglobin, which helps with the oxygenation and everything. And that is why sickle cell disease can be controlled a little bit. But in COVID-19 patients, if somebody is taking hydroxycarbamide, they may be mildly immunosuppressed, which might cause issues with their handling of the infection. So that is sickle cell. Any issue so far? If we are okay with this, I'm going to move to the next one, and that is thalassemia. And the remaining topics are really easy to, they're fast. So I'm just looking at the chat here. Anything that is interesting? So I saw somebody saying, Shireen said that, sorry, Dr. HbSC as well. So yes, hemoglobin C, or the chain C, is instead of the valine, there is lysine, but I would just consider it in the same state. Okay, so let's continue with thalassemias. So thalassemia, in the sickle cell, as I said, there is a problem with the chain, beta chain, that is defective. It is bent incorrectly. And that bend keeps tangling with other alpha chains in other hemoglobin molecules, and that causes precipitation. In thalassemia, there is an altogether absence of the chain. So that means if we make a chair, we may have a chair with 3 legs and 1 leg is missing. Why? Because one chain is not formed in correct order. Or maybe we have a chair with 2 legs and 2 legs are missing. Why? Because the chains are not formed. Or maybe we can have a chair with 1 leg. Can we have chairs with 2 or 1 leg? Anyways, so we have a chair with 1 leg and other legs are missing. Or we may just have a chair with no legs. All are missing. So see, the difference of thalassemia from sickle cell is that thalassemia has absent chains. Sickle cell has defective chains. That is a basic difference. So we say that medically as one has a quality problem, sickle cell has a quality problem, and one has a quantity problem. Thalassemias are a quantity problem. Okay, so going back here. Thalassemias are of two types, alpha and beta. And alpha, remember we talked about the chair to have alpha and beta chains, correct? Two legs are alpha and two legs are beta. So when alpha legs are less or reduced in quantity, normally our body would produce alpha and beta legs in equal amounts. So for example, if you're going to make chairs, every chair needs 4 legs, 2 are going to be alpha and 2 are going to be beta, then we have to make 4 or 8 or 12 and so on, so that these legs can be coupled and put together on the chairs or hemoglobin molecules. But what happens is, in this case, instead of an equal amount of alpha and beta chains, there is an unequal amount of alpha and beta chain formation. So if alpha chains are less, then that is called alpha thalassemia. And here is the interesting thing. Alpha thalassemias themselves can be of 4 types. And how does that work? What happens is, this is chromosome number, these are chromosome number 16. This is a pair of chromosomes, number 16. On this pair, there are 2 genes to make alpha chains. There are 2 genes each. So there are a total of 4 genes. Now it is possible that one of the gene is not working correctly. So that means we have 2 genes that are working okay. Sorry, 3 genes that are working okay and 1 gene is missing. If that is the case, the patient would still make enough hemoglobin A chains or alpha chains that we can have almost normal hemoglobin. So this is why it is called a silent alpha thalassemia. It is nothing big. It's fine. No problem. Then if there are 2 genes that are deleted or not working, and that 2 genes can be deleted in either way, either both on one chromosome or one gene from one chromosome and the other gene from the other chromosome. So that means we may have something like this. So one chromosome has both genes missing, other chromosome has both genes present, or one gene missing, both chromosome has one gene and one gene missing on both. Both are the forms that can be there. So this is called a alpha thalassemia trait. This is still okay. The person still has enough genes to make enough alpha chains that they are able to make normal hemoglobin and function normally. So that is good as well. Good. Then if there are more than one, there are 3 genes that are deleted or not functioning. That means there is one more gene here that is gone. So now 3 are gone. We are left with 1 gene only that is trying to make alpha chains. Then we have a disease. This is the alpha thalassemia disease. Now the patient would have issues, which are the hemoglobin issues. And if all 4 are missing, so here there were 3 missing. If all 4 genes are deleted, then that is hydrop fetalis, and this child can normally not, child is not born alive, child dies. So this is the alpha thalassemia. On the other hand, if the beta chains are absent, beta chains only have 2 genes, that means 1 gene and its copy on chromosome number 11. So here, if 1 gene is not working, then it is called a trait. That means 1 gene is still working, we are still making enough beta chains that we can still make hemoglobin, so it's okay. But if both genes are missing, then that is called major disease, beta thalassemia major. So that is how the thalassemias occur. Now, what is a problem with the thalassemia in context of COVID-19? So look, what is happening in thalassemia? We have bad hemoglobin. We have hemoglobin that is not correct. The result of that is that our body, ask the bone marrow to make more RBC. Body thinks that maybe there's a problem with RBC. So it asks the bone marrow to make more RBC. The result is that there is a RBC manufacturing going on everywhere in the bone marrow and in spleen. And that in turn would cause a very large spleen. Secondly, because even after asking the bone marrow and the spleen to make more RBC, RBC still are going to have defective hemoglobin. So such patients would need transfusions from outside. And here are the two problems that are important. Number one, patients of thalassemia may have become asplenic. Their spleen may have been removed. Although nowadays in modern medicine, spleen removal is rare, but in the older times, spleens used to be removed. A patient whose spleen is removed would get capsular bacterial infections. So if that patient of thalassemia who is asplenic, if they become infected with any viral infection, including COVID-19, it is possible for them to develop bacterial infections on top of it, which is a bad risk. So that is one risk of thalassemia patient. Second risk, plasma products. So the plasma products that they are getting may transmit the viral infections because the fresh frozen plasma that is given is not very effective. So normally we give cryoprecipitated plasma products. What does that mean? That we take some, let's say, factors from the plasma and we precipitate them, and then we create a more concentrated product. And if that is given, cryoprecipitated products would not have enough antiviral activity done on it. So we cannot do virucidal activity on that. But even before the plasma, more important for these patients is blood transfusion. And if they are getting continuous blood transfusion, then they are at risk of blood-related issues, including iron overload. Again, blood transfusion itself is not going to make COVID-19 severity change. Similarly, iron overload normally does not change the severity. So we should be okay, but that is a risk. And finally, in thalassemia, it is possible, forget about the plasma in this context, it is the blood transfusion that is more important. Adrenal insufficiency is found in these patients as well. So their suprarenal glands may not be working correctly, which means that these patients may need glucocorticoids. And that is another risk factors with COVID-19, that steroids can actually reduce the clearance of COVID-19 virus. So one has to now balance the fact that how much is the glucocorticoid needed by the patient versus what is the risk of COVID-19 disease becoming severe because we are giving steroids. Generally, I would say that compared to sickle cell, thalassemia patients have less to worry about. So now, if this much is clear, I'll keep asking. Then we'll go to our next topic, and that will be the hemophilias. So Hope is asking that, speaking of the transfusion, how are the trials for plasma from patients with antibodies going? They are going very good. So convalescent plasma is really useful for a patient who is in a critical state or serious state. So the convalescent plasma, as we have discussed before, it gives them enough time, because we are giving antibodies from outside which are going to be fighting with the virus inside the body. So now the virus is busy with the convalescent plasma, and the patient's own immune system gets a chance and time window to develop their own antibodies. So that should work fine. So Cliff is saying that, does the three issues for thalassemia goes for both trait and major? I would actually say that yes. Normally trait does not progress to a point where we are giving transfusions, or we are giving their adrenal insufficiency is present, or their spleen is being removed. So normally trait is something that is just a minor nuisance, and that's it. Mostly it is the major forms that cause full-blown disease, which then can cause the spleen issues or spleen removal and blood transfusion, not the plasma here, and then the adrenal insufficiency. So does that make this clear, Cliff? Hope you're welcome. Okay, so I think we're good with this hemoglobin disorders. I'm going to move towards hemophilias.